So if you have any questions, I'd be glad to answer. Thank you very much.
Good afternoon, everyone, and welcome to our Q&A forum. Thank you, Dr. Sakrana. I really enjoyed your lecture, Dennis, and I'm sure our participants did as well. I must commend you for making a complex topic easy to understand. Now, the data on immunotherapy is impressive, you know that. It gives us higher duration of response, higher rate of complete responses, and even prolonged survival compared with other systemic treatments, especially chemotherapy. Now, you did explain it very clearly, no? But I'm wondering, no, we're both oncologists. How do you exactly tell your patients about immunotherapy?
But it's simply, I usually tell them that immunotherapy is different from chemotherapy in the sense that it doesn't really kill cancer cells directly. It just allows the patient's immune system to be more active so that the immune system of that patient will be the one to attack the cancer cells. So that somehow provides them more courage to attempt to undergo these treatments because at least they forget about the killing of good and bad cells that they usually hear about with chemotherapy.
Yeah. So how is the uptake of the practitioner, especially oncologists, with this new treatment? What do you think will be the limitations its use in terms of the perspective from the doctors and also the patients?
I think immunotherapies are quite acceptable now to a lot of oncologists because of the many clinical trials that demonstrate its superiority over conventional chemotherapy in terms of providing better overall survival or progression-free survival. And as I said, the duration of response is really quite remarkable. Perhaps one major limitation is really the cost. It's quite the cost is quite prohibitive for many of our average Filipino patients, and so this is something that we really need to further through patient access programs or through financial institutions that can help make the drugs more accessible and more affordable for the patients.
Yes, I agree with you. No? I remember one of my patients with early breast cancer who was hesitant about chemotherapy, asking me if she can just be given immunotherapy. So clearly we know this is not for everyone. So actually this is also a question from the audience. No? So what patient populations are better candidates for immunotherapy versus conventional chemotherapy?
There are a few patients who we are able to identify who would benefit really from immunotherapies, and this is where the role of biomarkers come into play. Just like in the lecture earlier of Dr. Fernando, we emphasized that biomarkers are really very important in selecting patients who would benefit from these very expensive drugs. They're expensive but quite effective, so we need to make sure that our treatments are cost effective. So
Yes.
we're talking about biomarkers. In immunotherapy, one of the more common biomarkers would be PD-L1, which is as I discussed in the lecture earlier, it's a protein found on the surface of tumor cells, and the level of expression of PD-L1 predicts better responses to these immunotherapy drugs. So aside from that, there are other biomarkers that we can use, such as MSI, as I mentioned in one of the slides earlier, and also tumor mutational burden. So there's some biomarkers that we can use in order to select which patients are going to benefit from this therapy.
So as you mentioned, there are several biomarkers. Do you think there is such a thing as a best predictive biomarker for this treatment?
That's an interesting question because at this point there's still a lot of studies that we need to make in order to establish which of these biomarkers will need to be useful in selecting the right patients. The problem with PD-L1, although it's more widely used as a biomarker, is that you see it's not a perfect biomarker. You see some inconsistent responses. For example, the drug atezolizumab can sometimes be seen to be effective even in patients who don't demonstrate PD-L1 expression. So that's something that we really need to understand understand more. So studies are really being made in order to search for a better biomarker. But as of now, I think what is widely accepted is PD-L1, LSI, and tumor mutation rate.
Yeah, so as you mentioned, so we have to check the trials, so which one was which predictive biomarker was used in that case. So another question from the audience: how can we compare conventional chemotherapy, targeted molecular therapy, which was discussed earlier, and immunotherapy in terms of cancer outcomes?
Well, these are all parts. These are all drugs that include the treatment armamentarium, and they have their own roles. Chemotherapy, we know, is non-specific. It kills cancer cells for certain tissue types. But for targeted therapies and immunotherapies, they're more specific, meaning there are certain biomarkers that will identify which patients will respond better to these drugs. And so what I would say is that perhaps chemotherapy is more like it's like when they usually compare this to an atom bomb, it kills almost everything in its path. Whereas targeted therapies, they usually compare them to snipers who are more accurate. They have specific targets, and so you just have to learn how to use these drugs in specific situations.
I agree with that. I also use the term sniper. So for this treatment, what are the common side effects of cancer immunotherapy, and what should we watch out for when opting for this treatment?
When we treat patients with immunotherapies, we usually expect immune-related adverse events because we're trying to activate the immune system. Sometimes the immune system can overreact and cause autoimmune phenomena. So some of the more common reactions that we see would be dermatologic reactions in the form of rash. You can also see colitis, presenting as diarrhea, pneumonitis, presenting as cough. So these are the more common ones, and these are the things also we have to advise our patients about. We have to tell them to report to us any symptoms that may indicate that there is an immune-related adverse reaction so that we can promptly address that.
Thank you, Dr. Satayan. Any last words for our participants?
Immunotherapy is really one of the hot topics right now in oncology, and it's what we call the in thing. Although it's not widely used, probably because of cost in the country, I think we still need to understand how this works, because if ever these drugs become more accessible and more affordable, we'll be using more and more of these drugs. So, general internists should be aware of what can happen if patients are treated with immunotherapies, and should be prepared as to how to manage them.
Thank you very much. Again, we'd like to thank you for sharing your time and expertise with us. And truly, these innovations and developments are remarkable, and it really impacts the survival of our cancer patients. And we're looking forward to more research and clinically relevant strategies in the future. Thank you, everyone, for participating in this session. Enjoy the rest of the summer.
Thank you, Dr. Sakdalan, for that simplified